Good morning. It's a pleasure to be back on the podium here again. Maybe I'll have something interesting to say. When I was asked to give this talk, I thought that I would talk about atrial fibrillation and stroke as it relates to cardioembolic events. Did not specifically made a topic of a stroke on itself, especially hemorrhagic stroke. As far as ischemic stroke, there's little evidence, but not surprising evidence, that coronary calcium may be a predictor of ischemic strokes in general. But you know, atherosclerosis is atherosclerosis, so having coronary calcium should not be a surprise, would be a predictor of ischemic stroke. So in this context, I will talk about atrial fibrillation and embolic stroke. That is the topic that I thought would be more interesting. No conflict of interest. So a few statements about atrial fibrillation, just to put it into perspective. What are we talking about? Multi-million people, both in North America and in Europe, as well as Asia, are projected, are currently sick with atrial fibrillation, but also are projected to be diagnosed with atrial fibrillation in the next few years. You can see here tens of millions of people are expected to be affected by 2050. 72 millions in Asia alone, with about 3 to 5 million atrial fibrillation-related strokes. Men are affected more frequently than women. The lifetime risk of atrial fibrillation is 1 in 3 to 1 in 5. So 1 out of 3 people, especially among Caucasians, will be expected to develop atrial fibrillation. It's a very high incidence if you think about it. It is highly age dependent, of course, and over 10% of people above the age of 80 have atrial fibrillation. And this leads to an enormity of visits in the emergency room. As you can see here, about 600,000 emergency room visits just for atrial fibrillation, not comorbidities, in the United States, with about 500,000 admissions per year. It's a very large impact. It contributes to about 150,000 or 60,000, about 200,000, whatever that is, deaths per year, not just related to atrial fibrillation, but to the comorbidities. There are multiple scores that help estimate the risk of stroke and in atrial fibrillation. But as I will show you in a moment, they are driven by mostly morbidities that are actually limited in the scope when these scores were developed, and should include more than what they include. And finally, the economic impact of this disease. If you look at a person, 60-year-old, without atrial fibrillation, the lifetime cost is about $5,500 per year without developing atrial fibrillation. When the person develops atrial fibrillation, the cost goes up to $22,000 per year. It is an enormity of an increase, especially if you talk about millions and millions and millions of people with $22,000 on average cost per year. So we are talking about a very serious problem here, not a minor problem. I would like to point out that I come from the green area of the world up here, not the 51st state, even though you may have heard differently. The green part is called Canada. It will still be called Canada even tomorrow morning, no matter what bombing is going to happen. Anyway, in Canada, the age standardized death rate is about 3 to 4, deaths per 100,000 people with atrial fibrillation. As you can see, other areas of the world are quite different. And the United States actually, unfortunately, rank pretty high in the death rate due to atrial fibrillation and its comorbidities. What is a risk factor for atrial fibrillation? There are many, actually. I already mentioned age and sex, male sex and older age. But there are many more, as you can see here. Obesity, physical inactivity, as well as, notice the little asterisk, excessive physical activity. I warn you that if you want to run 3 marathons a week, you're putting yourself at risk. There is actually a very high risk in extreme athletes for development of atrial fibrillation. Multiple reasons why, we're not going to go into that, but definitely myocardial as well as atrial remodeling, both electrical and morphological remodeling. But there are many others, as you can see there: smoking, alcohol, sleep disorders, even social determinants of atrial fibrillation, such as, for example, poor air pollution, poor environmental health, air pollution. Neighborhoods where you live, you will say, what does a neighbor have to do with it? Well, are you able to exercise? Are there recreational activities that are available to you? Can you walk on sidewalks? Or like in the United States, there are no sidewalks, so you have to drive a car every time you go pick up your mail. So neighbors have a lot to do with it. And obviously, neighbor also leads to obesity. If there are what we call food deserts, where you cannot really get good quality food, but just fast foods and poor quality and nutrition. So as you see on the side here, I put up the CHA2DS2 score. This is the score that we used, the most advanced one we used to predict who's going to have a stroke in the next 3 to 5 years. And you can see that the list of risk factors where we consider as potentially predisposing to stroke include very few of the many that I listed on the left side. So as I said earlier, the tools that we have to predict potential thromboembolic strokes are quite limited compared to what we should be considering. Therefore, a number of biomarkers have been developed and a lot of monitoring systems have been developed, and a lot of other tools that we will talk about in a moment. So what are the diseases associated with atrial fibrillation? What does atrial fibrillation lead to? We just said it multiple times, stroke, yes, that's easy. But in reality, there's much, much more related to atrial fibrillation that we can consider. Cognitive decline is a big one. There's a large cognitive decline in patients who have probably microembolism over a long period of time, suffering from paroxysmal atrial fibrillation, for example. Dementia, obviously, as a consequence of cognitive decline. One that is really surprising, cancer. There's a higher incidence of cancer in patients with atrial fibrillation. GI as well as lung cancer as well as others. The connection there is quite obscure to me, but it has been reported several times. Other things you can see here: pulmonary embolism, myocardial infarction, heart failure. Heart failure is a big one. We admit tons of patients from the emergency room with atrial fibrillation and heart failure daily. And whenever I work in the wards, that's probably the majority of the patients I admit today. So I talked about several of the factors that predispose. I want to point out here specifically obesity as one of the risks. Notice the green Hulk over there, excessive exercise, as I mentioned earlier. But obesity, why obesity? Because obesity essentially is a pro-inflammatory state. And everything that can possibly go wrong in the human body goes wrong during a development of obesity. So chronic inflammatory disorder that affects many organs, specifically the visceral fat, of which we will talk in a moment. Obese patients tend to have more obstructive sleep apnea and therefore pulmonary hypertension than patients without sleep apnea. They also develop a gastroesophageal reflux. That's also a predisposing factor to develop atrial fibrillation through multiple mechanisms we're not going to go through. And patients with obesity do have an enhanced hyperactive renin-angiotensin system and sympathetic drive. So there are many reasons why patients with obesity develop atrial fibrillation. This is relevant as we will talk in a moment about potential interventions. So what is going on at the level of the atrium when somebody develops atrial fibrillation? First of all, let me repeat something that we always teach in the cardiology words. Atrial fibrillation begets atrial fibrillation. In other words, once you have it, you will keep it, and you will get more and more of it. But there's another saying that is very important and has been shown many times over. Patients with dilated atria tend to have more atrial fibrillation, but it's also true that atrial fibrillation induces atrial dilation over time. So the strain and stretch of the left atrium is a very important marker of predisposition to develop atrial fibrillation, as well as having had atrial fibrillation for a long period of time. So LA strain and remodeling, therefore, is a predictor of atrial fibrillation and also a predictor of poor outcome in patients who have associated heart failure. It may be the consequence of LV systolic dysfunction as well as diastolic dysfunction, not just one type, but both, as well as multiple, as I described earlier, neurohumoral and inflammatory pathways. There are therapies that may actually induce some counter remodeling of the left atrium, such as ACE inhibitors and angiotensin receptor blockers, weight loss interventions, GLP-1 receptor agonists, and we will chat about it in a moment. Whether all of this, whether the counter remodeling of the left atrium actually translate into patients' improved outcome remains to be proven. So I'm giving you a lot of information, but you should be asking me the question, so what? I will give you a potential answer at the end of this presentation. I mentioned that there are many ways to detect or at least identify patients who have atrial fibrillation. This is prevalent atrial fibrillation, patients who already have it or think they have it because they report to you palpitations. In this particular session, we want to talk about prediction of atrial fibrillation. Who's going to have it tomorrow, not who has it today. But as far as identifying patients who have atrial fibrillation, we have multiple approaches that we use in clinics today, such as a simple physical exam, that old thing that maybe the students still do, but nobody else does. We do have automatic blood pressure monitors that do report on rhythm variances, single lead ECGs, not very specific, mobile health technologies. Who doesn't have a phone or a watch today that reports on some of these electrical instabilities? But let's go to imaging. How about a good old chest X-ray? Do you remember how to look at it? Maybe. We just look at, for example, the profile of the left ventricle and the left atrium. We may be looking at the displacement of the left bronchus, as you see here on the left of the image. This is in PA and lateral views. That's a simple approach. Is it helpful? Maybe. It tells us probably very non-specifically whether there is a left atrial enlargement. But what about more sophisticated imaging? Let's talk about chest CT. This is one of the earlier publications looking at the association of left atrial dimensions and epicardial adipose tissue, which I will talk a bit more in a moment, as a predictor of atrial fibrillation in the large population study called Heinz-Nixdorf recall study. This has been going on in Germany for over 20 years. And the conclusion there was that, yes, if you measure very simplistically the area of the left atrium in a non-contrast enhanced CT, you can actually predict the occurrence of atrial fibrillation in the next 6 to 7 years, as opposed to just looking at risk factors. So the CT by itself is better than considering all the risk factors together. However, when you the epicardial adipose tissue also has an impact on this. I'll talk about epicardial adipose tissue in a moment. Here's another publication from Denmark, the Dan Kavas study, also with the same conclusion that the larger the left atrium on a non-contrast enhanced CT, the greater the probability of developing atrial fibrillation in the ensuing 3 to 5 years. You can see that the increase in risk is very obvious. There's also an increase in thromboembolism risk, as you noticed at the bottom of this graphic. Now AI, because we obviously have to talk about AI heavy presentation, has also been tested for this. This is AI applied to measurement of left atrium, right atrium, left ventricle, right ventricle volume, and the probability of developing atrial fibrillation. In this publication, where Dr. I-ELCAP is a co-author, the AI-driven assessment of left atrial volume is actually better than the CHARGE-AF score. CHARGE-AF score is one of the many scores that we use in clinics to predict who's going to develop atrial fibrillation. This is not a score like CHAD-VASc that is used to predict who's going to have a thromboembolic event. CHARGE-AF is a score to predict who's going to develop AF. And as you can see here, AI does better than the clinical information. Another publication on AI, now this time comparing CT assessment of the volume, chamber volumes, versus MRI assessment of chamber volumes. This is in the MESA, a multi-ethnic study of atherosclerosis, a study that has been going on for over 20 years, again, in the United States. 3,500 patients, 500 cases of atrial fibrillation over a period of 15 years, and 140 strokes. So who did better? What do you think, MRI or CT, enhanced by AI? Well, actually they did equally well. So for once, AI did not beat the human eye. The human ability to measure left atrial dimensions by MRI was not, the AI was not better than MRI. In this case, at least we don't have a triumph of AI over human intelligence. What about EAT? EAT is actually a form of visceral fat that wraps around the heart under the visceral epicardium. It's a type of visceral fat that resembles very closely the intra-abdominal fat. It tends to be very inflamed in patients with obesity and patients who have developed in time coronary artery disease, heart failure, and even atrial fibrillation. All cells are infiltrating the epicardial adipose tissue, T lymphocytes, natural killer cells, mast cells, macrophages. These are all nasty cells that should not be there or should be there only in small percentage, but are present in very high percentage, in very high concentration in patients who develop all of these cardiovascular complications. It is believed that the epicardial adipose tissue surrounding the atrium, the left atrium, may actually cause such a degree of inflammation that over time the left atrial wall develops fibrosis, stiffening, and therefore electrical remodeling. In fact, there are multiple publications that have shown would like to go back. Multiple publications that have shown the correlation of both epicardial adipose tissue volume as well as attenuation with the probability of developing atrial fibrillation. Attenuation as a marker of infiltrated inflammatory cells. Is it true? Is it not? There are multiple publications in the field. And what is very surprising is that GLP-1 receptor agonists, semaglutide, dulaglutide, all of these drugs that are now used for weight loss actually have been demonstrated to reduce not only weight, but also the volume of epicardial adipose tissue. This is tirzepatide, a dual agonist, and not only have been shown to reduce the volume and density of epicardial adipose tissue, they've also been shown to reduce the incidence of atrial fibrillation in those who receive these drugs. And most likely, the effect is not simply and merely related to weight loss. There are other mechanisms, potentially anti-inflammatory, and potentially having to do with ceramide lowering. Now, ceramides have been mentioned here because my friend Stillman is fixated on the ceramides and the importance of this particular lipid. I will spend 2 seconds about ceramides. ceramides are sphingolipids. And as you remember, students, sphingolipids are part of the membrane of human cells. Some particular type of ceramides, the so-called short-chain fatty acid ceramides, are particularly noxious to the human health. They've been studied in multiple settings, specifically in predisposition to atherosclerosis. And even in patients with normal LDL, a high ceramide may be an indicator of risk for atherosclerosis development. Well, it turns out that GLP-1 receptor agonists actually have, first of all, ceramides are predisposing to the development of atrial fibrillation, and GLP-1 receptor agonists not only induce weight loss, not only induce reduction in epicardial adipose tissue, they seem to have an impact on the reduction of ceramide concentration in the epicardial adipose tissue. So you can see that there is more to these drugs that meets the eye. So I'm done with this, just a curiosity, because I do a lot of nuclear imaging. If you see activity in the atrial wall with FDG imaging, this is now PET imaging. PET-CT, of course, is used now predominantly in cardiovascular imaging. That is also an indicator of risk of future development of atrial fibrillation, again, as a marker of inflammation and fibrosis of the atrial wall. So I'll conclude here with a few lines. Can we use imaging markers to predict atrial fibrillation? Yes. Do we have treatments that can modify the course of AFib and stroke? I talked about counter remodeling. I talked about ceramide modification, obesity approaches. Have we demonstrated that we can change the natural history of the disease? So far, not yet. Thank you for your time.